Hi friends, today I am going to demonstrate the simplest way of doing a combined cataract surgery and trabeculectomy. The superior rectus suture is done as usual we do in a cataract surgery. Now, as usual, I am going to take a fornix based conjunctival flap between 10 o'clock to 2 o'clock position in the superior limbus. Now I am making a straight incision, that is partial thickness incision in the sclera 3.5 millimeters above the limbus. After that I am making a pure scleral tunnel. In small incision cataract surgeries we make a sclerocorneal tunnel, but here I am making a pure scleral tunnel. I am not making any tunnel into the cornea. In small incision cataract surgery, we make the incision 2 millimeters above the limbus. Here I have made the incision 3.5 millimeters above the limbus. Now I am making a side port entry around the 8 o'clock position. I am also entering into the anterior chamber through the scleral tunnel at 12 o'clock position. I am injecting the trypan blue into the anterior chamber to stain the anterior capsule of the lens. After few seconds, I am washing the trypan blue from the anterior chamber. You can see the anterior capsule looking little bit bluish in color. Now I am forming the anterior chamber using the viscoelastic substance. Since this is a mature cataract and this lens seems to be having little bit of phacodonosis, I just did a can opener type of capsulotomy in this case. You can see when I am doing this capsulotomy, the lens is moving. This is because of the weak zonules. Before doing any step, we should inject viscoelastic substance to protect the tissues from damage. Now I am going to extend the wound on the superior aspect because we have wanted only at 12 o'clock position before. Now I am extending on either side from 10 to 2 o'clock position. I am just prolapsing the nucleus into the anterior chamber and getting the nucleus out of the eye by just using the viscoelastic alone in this case. Now you can see that there is no cortex at all in the capsule because this is a very high mature cataract. after injecting viscoelastic substance, I am just placing the intraocular lens into the capsular bag. I have placed it in the capsular bag. Now once again I am forming the anterior chamber using viscoelastic substance. Now I am going to create a flap for doing a trabeculectomy. I am just clearing the blood of the wound already we have fashioned. The anterior lip of the tunnel, that is the anterior lip of the sclera, is cut on either side of the 12 o'clock position. The flap is about 3.5 millimeter into 3.5 millimeter square flap. I am lifting the flap. You can see a nicely designed flap. You can see the posterior scleral lip. I am just making a entry into the posterior scleral lip. I am going to take a button of the posterior scleral lip. So because I have done so many cases, I am just cutting the posterior scleral lip using the keratome itself, but beginners, you can use the scissors to do it. I am using the scissor to cut on the other side. I am holding the posterior button and cutting and removing it. Now after removing the posterior button, you can see that the iris tissue is seen below that. Now using the forceps, I am holding the iris on the periphery and I am doing a peripheral iridectomy. You can see that the pupil has become irregular because I have pulled the iris through the wound. Now I am just trying to form the anterior chamber. Once I form the anterior chamber, you can see that the pupil becomes round. So trabeculectomy has been done. Now it is time to suture the wound. The central flap is not touched now. I am just suturing the tunnel, that is tunnel on either side of the central flap. On the nasal side and temporal side, I am making single sutures on either side. I am suturing the tunnel on the other side. This patient is bleeding very heavily because he is a cardiac patient who was on treatment with antiplatelets for years together. Despite stopping the antiplatelet drugs for 5 days, he is still bleeding. I don't want to apply cautery for this patient because the cautery will make the sclera irregular and rough, and the cautery will also lead to dry eyes later. Now I am going to suture the central flap. You can see that I am lifting the central flap. I am entering the suture there, and through the sclera on the opposite side, I am making a single suture in the center. You can see there is a patent peripheral iridectomy just above the central flap where I am doing the sutures. You can see a small black hole in the portion just above the suture being done. I am not applying very tight sutures because if you apply tight sutures, the aqueous drainage will be affected. The trabeculectomy will become a waste. We have to apply a firm suture. After completing suturing of the flap and the tunnel, I am now suturing the fornix based conjunctival flap. So that there is no bare sclera seen above the superior limbus. Now you can very clearly see the peripheral iridectomy at 12 o'clock position. The patient is still bleeding because the patient has been taking antiplatelets for so many years. Now you can see on suturing the conjunctiva back into its position, no sclera is visible. Now I am going to clear all the viscoelastic substances using the Simcoe cannula. While doing this itself, I am able to visualize the fluid flowing through the flap taken for trabeculectomy, and the fluid is getting collected below the superior conjunctiva. But because this video is not properly positioned to show that, I am not able to show it to you. I have injected the injection SC decadron with garamycin into the inferior conjunctiva. Unlike the surgical techniques we followed those days, this is a very simple technique which I have done for many cases and I have been successful.